We can also talk about health expenditure per capita and show some disparities in that area as well. The U.S., as most of you would know, probably spends more on healthcare than any other nation in the world, and it's in fact 19% of the gross domestic product. So a huge industry in the United States. Canada is not far behind, actually, and we're doing about $6,000 per capita, but probably maldistributed when we talk about our indigenous and other minority communities in Canada, but it represents about 12% of the GDP. As you get down into Africa, though, you can see that the health expenditure per capita is very low, representing 3 to 4% of GDP. An intermediate income country like South Africa, certainly higher, but nowhere near the rates that we see in U.S. and Canada. And you could argue that maybe we shouldn't be spending that percent of GDP on healthcare, but clearly if we are going to spend it, it has to be better distributed to those in need. And this is the cartogram again, percent spent on health, and you can see the, let's call it obesity of the U.S. spending in health on the left compared to others. And if you look in the middle, you can see Africa, a tiny little portion of this cartogram, representing very low percent of GDP spent on health overall in that continent. There are many disparities in healthcare, nurses and doctors. This is data from doctor about the number of doctors per thousand population. And you can see the US and Canada are fairly equivalent. But when you get down into the African countries, India, a little bad, but take a look at Malawi, where is it 5 per 100,000 population compared to 2.6 in the US for 1,000. So obviously a lot of doctors. And I do have some issues with physicians from the developing world coming, that we sometimes poach healthcare workers from the developing world to serve our own needs. And this again creates some more disparities in the countries where they were born and raised and trained. If we look at specifically at HIV spending, and this is HIV government spending in millions, you can see the U.S. is spending about $7 billion, $7.7 billion per year. Canada, a minuscule amount, but of course a much smaller country, but only 46 million. And I was surprised actually to find that South Africa was spending a lot more on healthcare in terms of HIV than Canada. And again, it's a middle-income country, so perhaps that's appropriate. Nigeria, which is certainly with its oil wealth a little bit wealthier than some of the sub-Saharan African countries, is spending $519 million on HIV programs at the last check. Don't have the data for Uganda, Malawi about 260. If we look at where the HIV spending comes from, there's some dramatic differences. This graph shows three things. One is in the purple is the development assistance for health spending. In other words, the contribution of other countries, NGOs, etc., to HIV spending. The orange bar is domestic spending. In other words, money that comes from that. And then the potential for additional government spending, meaning can those countries expand the domestic spending, is shown in the green. And as you can see, there are some dramatic differences. In South Africa, there is a lot of domestic spending, not as much development assistance, but a potential for more spending if managed properly. If we go down to Malawi, almost all of the spending on HIV care is from assistance programs, and there's a very small amount of domestic spending with really no potential for additional government spending. Uganda is quite similar in that regard. Nigeria, maybe a little more potential for government spending, but and India as well. But there are major differences in where these monies come from. Now, going to turn a little bit to anecdotes and some of my own experience in the developing world. And one Western misconception is that healthcare in resource-limited countries is somehow free and comes from government sources or NGOs such as mission hospitals that I worked at, for example, in India. But in fact, when you get down to brass tacks, patients and families of the patients bear a significant part of the healthcare costs for that individual when he or she is hospitalized with an illness, whether it's HIV or other illness. And these costs not only include laboratory investigations, but also nursing care, laundry, food and drugs, transportation is necessary. That this is a burden that the families of the patients have to bear. This is just one example of a man I saw some years ago now in Uganda. He's an elderly farmer. He actually had lost about. In India, I found this man with severe congestive heart failure. His son who had brought him in fact, we wanted to admit him for his care, but because the hospital was going to be charging 100 rupees a day, just a few dollars, the son refused to hospitalize him and took him home. Not sure what the outcome was. I don't think it was very good considering his underlying illness. This is an example in Uganda. This is the families of the patients who have to provide all the bed linen and blankets, doing the laundry and laying it out on the lawn outside Malago Hospital for drying. This is a common scene that you see throughout Africa. So the families are responsible for the laundry and linens of the patients. They do all the personal care as well too. Nurses really can start IVs, give drugs, but are really not involved in bathing or other aspects of patient care that we see and hear. There's a woman on the left who is taking care of her elderly mother in the Uganda Cancer Institute hospital. One of the problems here is that this woman is normally employed. She had a small business. But because she has to take care of her mother, she can't work. And on the right, a picture of the pediatric ward in Mbarara, again with the mothers doing all of the personal care for the infants. In India, the same thing. Here's a mother on the left who's giving oxygen through a tube to her child, because there wouldn't be any nursing staff available to carry out this task. And on the right, family members in a hospital in Assam, which is one of the tribal states of India, just north of Burma, giving care there. Just a footnote in terms of northeast India, which is above that zone, most of the infections there are due to drug use. And in fact, this is where a lot of the heterosexual cases in India derive from, would be from these tribal states north of Burma. If you don't have family, you're in deep trouble. Ill patients with no family often means they're not going to survive their hospitalization. On the left is a homeless man who was brought in by the police with obviously ill, but just on a blanket with no one to help. On the right is a prisoner who was sent in with tuberculosis and advanced HIV, again with no one to help. Some of the hospitals, in fact, Malago Hospital supplies a small amount of posho and an egg for a meal, only one meal per day. And the families have to provide the rest of the meals. But if someone is not there to actually get the meal from the cart for the patient, then they don't get fed either. So that's the importance of having family around. So let me point out some of the differences between these countries in HIV care. The beds are free, generally in South Africa and Uganda, for example. In Nigeria, actually, they're expected to pay a small fee, even in a public hospital, for the bed. There's really no social assistance programs in almost any countries, but South Africa, being a middle-income country, does get some social assistance, and so people can be eligible for that. Some drugs are free in Uganda. In South Africa, yes. In Nigeria, only the ARVs and some of the basic AIDS-related drugs like fluconazole and Septrin. Specialty care is not free generally in South Africa and Nigeria, although you can get a specialist for free in the hospital in Uganda. All of the countries offer combination ARVs, and as you know, therapy is getting better. Prescription times are longer. We have injectable drugs now, which speak to the issue of PrEP, a very important issue, which is going to be instrumental in ending the HIV epidemic. Coordinated TB programs are present in Uganda, not so much so in South Africa and Nigeria, good sign. And TB diagnostics generally are pretty readily available and improved with some of the new technologies, PCR, for example. What about mother-to-child transmission counseling? Yes, in Uganda, South Africa, Nigeria, and generally on site in most cases, although in South Africa there's usually not a specific program within the hospital to offer MTCTC. In terms of voluntary counseling and testing, to get an HIV test, it's available in all places and often on site in the clinic, although not in South Africa. And generally testing is not routine in hospital. It is in Uganda, but in South Africa and Nigeria things may have changed, but when I was there, patients had to ask for an HIV test. It wasn't done automatically. I mentioned the ARV prescription length. Generally, because drugs go missing, they want to make sure the patients are compliant with treatment. The prescription lengths are fairly short. But again, this is improving, and with some of the injectable drugs, I suspect, and certainly in Uganda, we can now do 6-month follow-ups in the clinic that I'm associated with there. So things have improved in terms of the need for a patient to come in for a visit to confirm that they're taking their drugs. Adolescent clinic available in Goodwin in Uganda, not so much in South Africa and Nigeria. And again, there are some PEDS clinics at various sites. And most hospitals and HIV clinics have very well-equipped trained counselors, often peer counselors, to deal with HIV-related issues. Transportation can be a major problem in getting, as you know, road systems in many of these countries are very poor, and patients have to travel long distance to get care. Only some support is offered in South Africa, but in Nigeria and Uganda, and also in India, transportation is not paid for. Here's an example in India of patients who traveled many kilometers to attend a clinic, and because of that, they are sleeping overnight in the hospital lobby before their appointments the following day. So transportation, a major issue. Special populations, I know this conference is about special populations in need, and we see these all over the world. Drug use, as we know, fuels the HIV epidemic worldwide, and drug users, we also know, are marginalized in every country, every city, every province. And in Canada, they represent about 20% of new cases. In India and Nepal as well, they have a special problem with injection drug use. I mentioned the Northeast Indian provinces, states where drug use is the driver of the epidemic there. But also in other patients. If you go to New Delhi, for example, and we always talk about India and it's shining and how things are going so well, but there are about 15,000 addicts that live just below the Red Fort in Delhi, and they're ministered to by a small Hindu hospice, and these patients live on the street. They inject heroin. Here's one of the hospice workers actually helping one of the addicts on the lower left find a vein. These patients also have to get food. It's difficult, and there's some food banks that do help with that population. Just across the border from a town called Raxaul in Bihar state in India, it's a little town called Nepal, or called Briganj in Nepal. And they had what's called a needle park there, and this are individuals live there in tents, scramble for food and care. Here you can see me examining a man with tuberculosis, and then on the right, another HIV positive man and his 8-year-old son who lived in this tent in Burganj. How do you pay for your heroin? Well, there's some interesting ways. One is prostitution. Here on the left you see a male prostitute. Down in that area I mentioned in New Delhi is addiction. So I just want to finish, where are we now in the pandemic? You can see that we are making progress with reductions in both HIV acquisition, that's the blue line, and also in the number of people who die from HIV-related causes. We still have a fairly long way to go to meet our 2025 targets, which are reducing deaths to well below, reducing acquisitions to well below 500,000, and we still have a long way to go to meet the 2030 HIV targets, and these are 90% reductions in HIV/AIDS. Parenthetically, I might say that I think with the newer PrEP agents, many of the clinical trials are being reported on for the long-acting injectable antiretrovirals that will prevent acquisition of infection in populations such as women. These, I think, hold some promise with meeting these 2025 and 2030 goals. By saying, obviously, where there's life, there is hope, and want you to remember that there is nothing that cannot be changed. So I want to thank you. I'll say Webleanyo to my Ugandan colleagues and Werava, but I want you to have a great conference, and thank you for letting me speak to you this morning.
Well, I know Professor Shlech is on Zoom, but he can still hear us. Thank you so much for all the great insights and information. I'm pretty sure we all have learned a lot today. Thank you, and hope you have a great family vacation wherever you are now. Thank you for dedicating this time to join us at our conference. Thank you so much, Professor Shlech.